Our next speaker is Dr. Ernest Aniteye, who is the Director of Anesthesia and Intensive Care at the National Cardiothoracic Center, and also Head of Department of Anesthesia of the University of Ghana Medical School. He is going to talk on the post-operative management of the cardiovascular and the thoracic patient.
My topic is on the post-operative management of the cardiovascular and thoracic patient. And it is a very, very broad topic. Why should we monitor our patients post-operatively? I think the main reason being that for most cardiothoracic cases, it's likely that you're going to have some morbidity and mortality. So if you detect them early, then most of your patients can be adequately treated. And I think it's important that if you decide to enter cardiothoracic or cardiovascular and thoracic surgery, then you should have properly equipped intensive care or high dependency units to manage your cases. We have a 6-bedded ICU and then a 5-bedded high dependency unit in the cardiothoracic center. We use our ICUs mainly, and then if there's an overflow, we use our high dependency units. I think you've seen a little bit of this picture. What he also shows is that we also see some degrees of lung injury, and this is a patient with a penetrating, he actually tried to fire the wrong bird, I think an African bird, and then the gun, a bird on a tree, and the gun exploded and the thing went into his chest. I think he had his surgery. Post-op, he did well and also went home. And then for our open heart and cardiopulmonary bypass surgeries, the common ones that they've mentioned are ASDs, VSDs. We may do a few AV canals and DOF, repair of the trilogy of Fallot, and then occasionally ascending aortic aneurysm. Sometimes our surgeons do that. We haven't started doing anything on TGAs or switch operations as yet. I think in the post-operative period, some of the important things are pre-operative hemodynamics. If your patient has significant heart disease, then you are going to get problems. The duration of the surgery, the ischemic time, as well as the complications that they got during the surgery, and then the amount of inotropes that they are using during surgery is also quite important. And then most of the time when our patients end up in the ICU, the important things that we normally check are normally, if our patients are intubated, endotracheal tube, a connection to the ventilator. The other hemodynamic parameters important is our chest tube, our urine output. Then, of course, our inotropes and drug infusions, whether they are running well and whether we have the correct dosages of these cases. The first laboratory investigation we do, which is from our blood gas machine in the ICU, are ABGs and then electrolytes. Then we do our hematological screens. And then normally if it's a cabbage, we have an ECG. Or if we think that the patient has some significant arrhythmia, that has to be looked at. Chest x-rays are also important, mainly to check our ET tubes, NG tubes, our chest tubes to make sure our lung fields are free, and then the tip of our CVP lines. Occasionally, if it's a subclavian line, it sometimes goes into the neck. Then it means your CVPs that you'll be measuring will all be wrong, and you won't be treating your patients properly. The ventilation will depend on the pre-morbid state of our patients, the duration of the surgery, bypass time, and whether they had any complications during the surgery. Ideally, we ventilate them as short as possible to prevent ventilator-associated lung injury and then ventilator-associated pneumonias. And if you see, this is an ASD. This is the first day post-op. The patient has been extubated. If there's a lung resection, especially a pneumonectomy, then we avoid ventilation, and as much as possible, we extubate them. We sedate most of our patients with a combination of morphine, midazolam, and we use bi-level ventilation for most of them, using the BiPAP assist mode as our main ventilation. And we are very aggressive with chest physio, use and then mucolytics. This is another small child. That is the first day post-op. For most of our cases, if they are very stable and we don't have any high use of inotropes, we extubate them on the first day. I'll jump that. And then some of the important post-operative things that we have to think about, especially after CABG, is our myocardial oxygen balance, whether our patients have a myocardial depression, or whether they have significant arrhythmias. That is very important in the outcome after that. We are very particular about perfusion, our cardiac output, blood pressure, and then we also have a feel about our periphery. If our patients are centralized, then it means that the systemic vascular resistance is high and then perfusion may be poor. We also have the luxury of having lactate on our blood gas machines, so we can actually check on perfusion. Acute management of low cardiac output states, we have to make sure that our patient hasn't had a pleural entry, a tension pneumothorax, hypoxia, a tamponade, or our inotropes inadvertently reduced, or if it's a CABG, is a graft thrombosed, or is a patient bleeding from any of the other vascular accesses that were actually used. To optimize our cardiac function, we look at the rate, the rhythm, our preload, afterload, and then, of course, our cardiac contractility. We maintain heart rates of around 90 to 100 beats per minute in the postoperative period. In our pediatric cases, we use much higher rates. And then, of course, we atrial pace if the AV nodes are functioning. And if they are not, and we need to optimize atrial transport, we sometimes use AV sequential pacing. And then for our CABGs and otherwise, if the heart rate is very high and it's affecting our hemodynamics, we may decide to actually treat these patients to reduce the heart rate. For preload, if the CVP is less than 12, we use crystalloids, colloids, or blood. And then the colloids we use are hetastarch and gelifusing, and then albumin in our pediatric cases. If the CVP is higher than 12, then we may actually look at our cardiac output, increase contractility, and then the afterload. Most of the inotropes we actually use are dopamine, dobutamine, adrenaline, Merinon, and noradrenaline in combinations. Normally, we would use dopamine, adrenaline, and then Merinon comes in when we are worried about the right side of the heart, or when there's pulmonary hypertension. We normally load our patients on the bypass, so our perfusionists normally struggle with the vasodilatation that they get, and then when we come off bypass, we continue to the continuous infusion of the inotropes. And then if we want to use a vasoconstrictor, noradrenaline is our drug of choice, although we have vasopressin as well. We don't actively use mechanical support, although we have an intra-aortic balloon pump. We've recently acquired an ECMO machine, and I think in due course we may be using it for some of our pediatric cases who have been giving us problems. I'll jump over that. Slognoff and Keys show that your postoperative complications may be related to the anesthetists that you have. So if you choose a wrong anesthetist in cardiac and thoracic surgery, your complications are going to increase 11 times. Okay, so a surgeon-anesthetist-perfusionist relationship is absolutely important for successful outcomes. Now, there have been a few mentioned mortality rates for electives, emergency, and then salvage operations. I won't go into those details. And I think Dr. Fallacy mentioned that, do we also look at the comorbidities? Yes, we look at them, but we don't actually quantify them before our surgeries are done, and therefore our mortalities are not really related to them. He talked about the personal score, which he thinks is important. But then, occasionally, some of the patients are so bad that we may decide to operate on them, although the postoperative risks may be quite high. Now, I looked at the cases that have been admitted into our ICU the last 3 years, looking at open heart and cardiopulmonary bypass surgery. 5 minutes, thanks. These are the values, a mean of about 75 to 80. Our closed heart surgeries about 60. And then our thoracic surgeries have increased dramatically in the last 2 years because there's a dedicated theater for thoracic surgery, which runs at the same time as cardiac cases. And then the other important thing is that if you look here, our surgeons have been doing quite a lot of AV shunts, about 150 in 2012. And I think in 2013, there are going to be more. The duration of ICU stay is about 3 to 4 days. The longest patient who has stayed in ICU is for about 42 days with systemic inflammatory response and multi-organ dysfunction. Those who go to the ward after the first post-operative day are the patients who we extubate quite early in the ICU. And then I also looked at the complications for thoracic and vascular cases and then our cardiac cases. So if you look, the important ones are in red: arrhythmias for thoracic and vascular, hypomagnesemia. Low cardiac output states, like Dr. Jan mentioned, is very common, sometimes very high inotropes. Nausea and vomiting, if you look at this value, I'll look at the others very soon, that is 2010. Hypothermia, because our patients sometimes take a long time from the time of bypass till they get to the ICU, so they get quite cold. And then hypothermia is something we get a lot of. And then, of course, hypomagnesemia. So that if you look at 2011 and 2012, the same complications actually run through. Now, because we've noticed that we have a lot of hypomagnesemia, we now give our patients magnesium while they are still on cardiopulmonary bypass. Nausea and vomiting has increased over the last 2 years, mainly because of the fact that we are using a morphine and midazolam infusions for our patients. I think we should give them more prophylaxis. Some of our patients get ARDS, a systemic inflammatory response. Which arrhythmias matter with us? I think fast AF after open heart surgery, and then supraventricular tachycardias, and then ventricular arrhythmias. We were having a lot of junctional ectopic tachycardias in our pediatric cases, but when we started using magnesium, that has actually gone down significantly. That's a junctional ectopic tachycardia. That is a broad complex or ventricular tachycardia. Hematologically, if our patients bleed more than 2 mils per hour for 2 consecutive hours, or more than 400 mils for 1 hour from our drains, we do our hematological screen, check our ACT, may give a little bit more of the protamine, FFP, cryoprecipitates. We use tranexamic acid routinely. And if we get into trouble with bleeding, vasopressin or desmopressin has been our savior in about 70 to 80% of the cases. And then neurologically, they say that some of the neurological deficiencies are about 5% from embolic air or particulate matter. We've had 2 strokes in the last 15 years, major strokes in one adult and one adolescent with brain infarction. The main problem we have is that most of our CABG patients wake up confused. And we've used paracetam as well as dexamethasone to manage quite a lot of them without too much morbidity. Sepsis, septic shock do occur occasionally, especially in our thoracic cases. This is a patient who had a ruptured esophagus for 2 weeks, and he was brought in septic shock. He had a thoracotomy, esophagectomy, feeding gastrostomy, and a cervical esophagostomy. And he had used a lot of inotropes. He succumbed to his disease after 4 days. He had a VSD repair, went into the systemic inflammatory response with acute renal failure. He was dialyzed, and he did well. We have a protocolized method of dealing with our sepsis using branded antibiotics to make sure that we get the right treatment. And when we do that, the mortality rate is remarkably reduced. Thank you very much. We maintain normal urine output after open heart of 3 mL per kilogram per hour. And if that is not enough, we increase our urine output by increasing our preload, inotropes, and then, of course, inotropic support. We don't have phenyldiapam or levosimendan, which are available, so we use a lot of furosemide infusion. Then, this is the last but one slide. We also do a lot of DVT prophylaxis for most of our thoracic cases if the risk of bleeding is not too much. And then we use PPIs routinely to prevent stress ulceration in our post-operative cases. And then this is the last slide. We actively feed our patients on the first day, post-operative day, for patients who can tolerate it, sometimes 6 hours after open heart surgery. And then we also use a lot of TPN, parenteral nutrition, for our patients who have extensive esophageal surgery. Our surgeons don't actually like feeding jejunostomies, so maybe we have to encourage them to use that. Thank you very much.
Thank you, Dr. Aniteye, for your very detailed and enlightening presentation. I'll now call our next speaker, Ms. Ernestine Togo, Deputy Director of Nursing Services with the National Cardiothoracic Center, and she's going to talk about the role of the critical care nurse in the practice of cardiovascular and thoracic surgery. Thank you.
The role of the critical care nurse in the cardiovascular and thoracic surgery in the sub-region. Nurses form a very essential part of the health team, and their roles become very enormous in the critically ill setup. The objective of this presentation mainly is to outline the activities of the critical care nurse in the management of patients with cardiovascular and thoracic surgery. This is an ICU environment, and it is built mainly on leadership, collaboration, team spirit, and sacrifice. This is a cardio ICU showing some of the staffs with a patient. Preoperatively, the nurse is very responsible for the care and the upkeep of the patient. Right from the time of admission, the nurse gets involved with the patient. And psychologically, the nurse takes that charge to find out from the patient what has been explained to him or her, because at the time that they were seeking surgery, or they have told them that they are going to have surgery, the anxiety of soliciting funds, the anxiety of surgery, the outcome of surgery, they don't actually pay particular attention to what the surgeon is saying during the clinical period. Then the physical preparation, and then preparation to receive the patient in the theater. We have to demonstrate and teach patients on relaxation therapy. The physical preparation that the nurse goes through is to assist the patient to have investigations done, look for signs and symptoms which could interfere with the progress of the operation, and clipping or shaving of hair, depending on the policy of the hospital, is done, and then thorough bath of the patient on the day of operation. Taking into particular notice the hair and the nail care, especially with our female adults. People come into hospital and then they know that they are going to spend a considerable time, especially the female. She will go and do her hair, make a very huge pony at the back. And they get to the theater area and then anesthetist is in trouble. He cannot flex the neck to be able to intubate. She came in with an artificial nail, which the pulse oximeter could not pick the oxygen saturation. And then she has a nail polish. These are the things that the nurse takes particular care to make sure that all these things are put in place. Ensure patient safety, hairpins, beads, rings, dentures are all to be checked, and then make sure that the patient is safe, and ensure empty stomach, bowel preparation, if bowel would be used, especially in the esophageal procedures. You take the baseline that are prior to surgery just to guide her exactly what the patient's outlook is, and after surgery, she can be able to determine whether the patient is running into a complication or not. She assists the anesthetist to pass lines if it will be done before sending patients to OR. I put this thing there because there are some areas who don't have a proper recovery ward, and they do most of the things on the ward before sending the patient to the theater area. Receiving the patient from the ward to the ICU is still the nurse's role to continue to make sure to identify the patient, the right patient with the right diagnosis, and then the right surgical procedure that is to be done. There are times that we hear that wrong side lung has been operated upon. So we have to be very careful with that. Cross-check the patient's checklist. Cardio ICU have a particular checklist, right from investigation to what the patient has eaten the last time before coming to the theater area. And you need the weight as well for calculation of drugs. Ensure patients transfer from one bed to the other, and then make sure patient doesn't fall out of bed. Then assist the anesthetist to pass lines. We are still preparing the patient, and during the intra-op, whilst patient is already in theater and operation is going on, the ICU nurse hasn't have a free day. She has to make sure the area that the patient is coming to occupy is very clean, right from the gadgets, the lines, and the floor, and make sure all machines are test run to see whether they are very functionable, emergency trolley well equipped for any emergency, and then prepare for post-operative investigations. And they liaise with the anesthetist from time to time to know what is happening in theater. Post-operatively, the main duty of the nurse is evaluating the patient's recovery process, identification of emergency situation, and then monitoring the patient to ensure that there is no complication. Immediate post-operative care. Patients arrived. Assess cardiovascular and respiratory function, level of consciousness, maintain adequate ventilation, maintain adequate circulation, identify and evaluate potential or actual complications, and then protect patient from injury. We have continuous monitoring of the patient's vital signs, and then heart rate to determine arrhythmias, blood pressure, SpO2, respiration, temperature, CVP, ABGs, and VBGs. And you know what all these things stand for. Management of pain, as he has described, and then other drug administrations. Chest tube, mediastinal tube care, renal function monitoring, where in ICU, urine become a gold. You have to be watching the urine and measuring the urine every hour to make sure that your patient's kidneys are perfused. Prevention of infection, which is very paramount to a patient like this, and then help in the treatment of sepsis. As patient is stable, things are getting on well. Nutritional needs of the patient you cannot ignore because he needs the food, energy, for repair, for immunity. Daily dressing of incision and drainage sites, personal hygiene needs, and then rehabilitating the patient when stable, and chest physiotherapy and passive and active exercises to make sure that your patient has attained its goal. And this shows patient satisfaction and then staff satisfaction. Conference. Thank you very much.
Yeah, thank you very much, Ms. Togo, for your very educative presentation, which has given us a lot of insight into the role of the critical care nurse. Our last speaker is Dr. Bode Falase from the cardiothoracic surgeon in Lagos. He's taking the presentation which was done for Prof. Ndeye. So we welcome Dr. Bode Falase, who is going to speak on thoracoscopic surgery, a review.
A quick introduction. Now, VATS is well established in the Western world. It started from thoracoscopy in the early 20th centuries, and with video endoscopy equipment, it gradually expanded through the late 80s. And currently in the Western world, it is part of the required training of a cardiothoracic surgeon. However, its use appears to be limited in West Africa. So I want to explore what experience I have come across, and we can discuss as to, is there a place for VATS or not in our environment? So as I said, very limited information. I got some information from my colleagues in Ghana from personal communications, which they sent to me, and I used my experience in Lasouth. I couldn't really find other experiences, so I would be interested in finding out if others in this room have experience in VATS, so I can add that to this the next time that it is presented. Now, the things I could find which were agreed to be indications, some of them are a bit of soft indications. Running through them, you have indeterminate solitary pulmonary nodules, indeterminate pleural effusions, the treatment of spontaneous pneumothorax, the diagnosis and treatments of malignant pleural effusions, diagnosis and treatment of empyemas, stematocytomies, lobectomies, fundoplications, cardiomyotomies, and even esophagectomies. A lot has been reported on these various things. Some there's a lot of controversy about, some are agreed indications. Now, what's the evidence base for some of these things? Looking at pneumothorax, overall it's agreed that using VATS for pneumothorax results in a shorter length of stay, there's less pain than thoracotomy, and overall there are fewer recurrences than just simple bedside pleural drainage and pleurodesis. For lobectomies, it's widely practiced, but it is a bit controversial. It's been shown that there's no clear advantage over open thoracotomy when you look at various indices, apart from post-operative pain. It is argued that you may not be able to perform as extensive a surgical procedure for cancer via VATS for a lobectomy as opposed to an open thoracotomy. So most of the proponents generally agree that they're recommended for early stage cancers, usually stage 1 lung cancer. For indeterminate pulmonary nodules, there's no controversy. It is the gold standard. Various studies have shown that there's 100% sensitivity compared to a very high false negative rates of things like CT-guided biopsy. You see the lesion, you remove it, and you get all the information that you need. For malignant pleural effusions, similarly, it has the advantage of both investigating and piloting the pleura simultaneously. Now, overall, studies have shown that it has a diagnostic yield of about 95%, compared to 44% from needle biopsy and 62% from cytology. The series from Ghana that is in the abstract showed that you had a cytology diagnostic rate of about 40%. And looking at the reduced recurrence from pleurodesis compared to bedside pleurodesis, similarly, the study I saw from Ghana in the abstract showed that following tetracycline pleurodesis, they had a recurrence rate of about 23.5%. So I think our experiences show that if we can afford VATS for the indeterminate pulmonary nodules and the malignant pleural effusions, there is a strong advantage. Fundoplications and cardiomyotomies, there's a clear advantage in reduced trauma, pain, and hospital stay. And the surgical procedure, unlike many other procedures, is not compromised. You do exactly the same operation by both means. There have been a few reports on esophagectomies for cancer. It's feasible, but the concern is that that procedure is actually compromised because you don't do the same procedure, the same dissection, and because you use utility ports, there's the potential of seeding malignant cells, so not very commonly practiced. One of the contraindications, now this now applies to our environments, where you have a patient who has an obliterated pleural space. In the you take the lung down, there's no pleural space, so there's no point trying the procedure. You've assessed the patient, and they can't tolerate single lung anesthesia. The patient's already had a contralateral pneumonectomy, so has just one dependent lung. It would be a bit risky to undergo VATS. There's respiratory failure or the chest wall involvement by tumor. Other contraindications, hemodynamic instability, coagulopathies, severe thoracic trauma and hemorrhage, inadequate instrumentation, inadequate training, because you must be trained for these procedures, and of course in the environment, the inability to afford the procedure. Now, what are the requirements? Some of these have been covered earlier. Adequate prep assessment, anesthesia equipment, adequate setup, adequate post-op management. Prep assessment doesn't differ much from the earlier presenters. Spirometry, blood gases, your routine bloods, and because there's always a small risk of converting to an open procedure, you must always have some blood available. Anesthesia has been covered, general anesthesia, single lung anesthesia, either via a double lumen tube or single lung with a bronchial blocker. And intraoperative monitoring, you must have the usuals, but pulse oximetry, ECG, and end-tidal CO2 to confirm your tube placements. Now, I'm coming to some of our experiences now. Double lumen tube has been covered earlier, so that's just a picture of a patient having a double lumen tube. We always use flexible bronchoscopy. This gentleman loves peering down the scope, as you can see. And we confirm the position. This is not very clear, but this is the left-sided bronchial tube. You can see the blue cuff of the bronchial tube on your left. You can see the carina very clearly. You can see the right main bronchus. So this way, we are sure that the tube is well placed. When one uses clinical means, sometimes the tube goes too far down, and you think you can hear entry on the other side. If you don't use the bronchoscopy and confirm your tube placements, when you then clamp the tube, the lung doesn't go down the procedure, you now begin to reposition, so it's a bit awkward. Equipment, open thoracotomy set, rigid thoracoscope, light sources, thoracoport, electrocautery instruments. We use a combined set, both for the video processor and the light source together, and this allows us to save images. We use a pediatric bronchoscope for our tube placements, telescope for the pleurodistis, bulb insufflator, trocars and cannulae of different sizes. And this is combining everything all together. So you have the telescope, the graspers, the trocars, and the various instruments. Of course, positioning is the same as for thoracotomy. Video monitoring, if possible, opposite the surgeon to have a good view. You must always triangulate your ports so you don't have what you call sword fencing, and you're working in a closed space, and you can't quite get things right. It's because you put your ports too close together. So you try to triangulate them at the apex of a triangle, if possible. That's the view at VATS. In this particular patient, had a large bulla. So the bulla is grasped for one port, apply a stapler across it, and fire to resect it. This was a patient who had a bronchogenic cyst. So that's the view at surgery, and that's the excised cyst postoperatively. And some of the advantages, I'm just showing the port placements, but also, rather than opening up the chest for this patient to remove the bulla, we've made 3 simple port incisions and got her bulla out. She had a bit of a hypertrophic scarring, but compared to having a thoracotomy incision, quite an advantage. For a patient with a suspected mesothelioma, we try to do, if possible, a single port. So through the same port, you pass your telescope, and beside it, pass your grasper, because all you're going for is the pleura. That last patient, that's the view at VATS, and following tetracycline insufflation, that's the view. Post-op care really need ICU. For us, we use oral analgesia, encourage insider spirometry, and early mobilization. This has been presented earlier, the Ghanaian experience. A lot of lung biopsies, cardiomyotomies. They had some for catamenial pneumothorax, a few bulectomies, had mass biopsies, and bronchogenic stations, about 37 cases in total. Our experience was actually over the same period, very similar number of patients. Our mean age was about 40. Our indications were mainly for interstitial lung disease, some for malignant pleural effusions, some for spontaneous pneumothorax, then a couple for indeterminate pulmonary nodules, 2 for empyemas, 2 for suspected pleural endometriosis, 1 for vaginic cysts. The VATS procedures done are shown. Results, I guess maybe from the case selection, they were relatively straightforward cases. So there were no conversions to thoracotomy, no post-op complications. We had no prolonged air leaks. All tubes came out at 48 hours. Main hospital stay was 4 days, and there was no major morbidity or mortalities. Now, everyone talks about the cost. For us, the startup cost, luckily we were sponsored by state governments. The overall cost of putting everything together, the minimum access equipment was just under ₦1 million. The video and endoscopy equipment was about 2.3 million, and the staplers, which we invested into start the program of, was about $500,000, coming to about 3.7 million. So converting that to dollars, about $24,000, but that's the startup cost. What's the cost per individual patient? Now, this is the costing I did for a VATS lung biopsy. The total comes to 335,000 naira, which is about $2,100. But the main cost there for us is the theater fee of 100,000 and cost of the staplers. So we can get that cost of the theater fee down and the stapler cost down. The other costs are not really huge. We put in a replacement cost of just the 5,000 towards replacing the equipment over time, though we look after it jealously and very carefully so it doesn't go bad. And the double lumen tube is only 18,000. So the major cost here is the cost of theater and the cost of the staplers. So in conclusion, so from what I've been able to find out, there's still a limited number of VATs being done. Good results from the limited series. Initial startup costs are high, and the cost of procedures are also high for our environments, and it's mainly from the cost of the staplers and theater. But there are strong indications for VATs, but I think its application will remain limited, so we address the issues of cost. Thank you.
Thank you, Dr. Falase, for this excellent presentation. Please come and join us at the... who do I choose? A couple from this side, please, in front. Yeah.
Surgery time is usually very precise. Dr. Aniteye, I just want to ask you a few questions. We're a little surprised at the number of patients who post-operatively had hypothermia. So I don't know if you have any comment on that, knowing the problems with hypothermia after cardiopulmonary bypass. And then for the post-op patients, you seem to have quite a number of patients who had post-op bleeding. I don't know, some patients had post-op bleeding and you had to do some coagulation tests for them. Considering the number of cases you do, wouldn't you consider getting TEG into your practice, the thromboelastogram?
Maybe sort of like a question for Dr. Falase concerning video-assisted thoracoscopic surgeries. For us in Benin, we have had a lot of challenge getting some equipment, but we've been able to do, I think, about 2 or 3 now. But we have essentially used equipment that are really not for thorax. We have used the hospital has a laparoscopic set for laparoscopic surgeries, which unfortunately the general surgeons were not using. So we revived them and used them. But we have essentially been using them for mainly diagnostics. In fact, patients we use them for people who had indeterminate causes of recurrent pleural effusions, and it turned out to be 2 of them turned out to be pleural endometriosis. Confirmed. But what we found using it, we found that it was much cheaper. So I was just wondering that maybe the costs, some of the costs you're talking about, are for those where you have to add therapeutic things to. Maybe because in our center, our theater fees are probably a bit cheaper than in your center. So the staplers, replacement fees, and some other high costs are not there. So it's actually cheaper for many of our patients because it really reduces their hospital stay. Okay.
This is a question for Aniteye, Dr. Aniteye. Have you risk factors for low cardiac output? Have you studied that? And concerning milrenol, when you get milrenol, when you get you have severe pulmonary hypertension, do you put milrenol before going to surgery to minimize the risk of low cardiac output after the surgery? Thank you very much.
Thank you. We thank Dr. Falashe for the beautiful presentation. I just have some comments to make because just like Dr. Okubo said, sometimes because of inadequate facilities and inadequate training, which we classified as contraindication, it only means that VAF may never be done in our own setting. So with the little training we have, what we do is that we improvise with the telescope that the gynecologists and the general surgeons use for their laparoscopic surgery. And then we get an adapter and connect to a computer. And it is proven to be very effective, especially in patients that have malignant pleural effusion, that you need to find the cause, maybe sometimes, because we rarely diagnose the mesotheliomas here, but if you do that for them, you can get the lesions very clearly, and you are very sure, especially in situations where our patients can't do a CT scan. And also, it's been very useful in malignant pleural effusion, pleural biopsy, and pleurodesis. I don't know why it's so costly in Lagos, but maybe because of location of Lagos and because you are using the ideal things for thoracoscopic surgery. But in our own setting, like Dr. Kubo said, is cheaper. And we use, like for the ports, we use the disposable ports. And those disposable ports can be reused over and over. The other ones, like the staplers, are usually borrowed from European counterparts.
Okay. Yeah, okay.
Thank you very much.
Thank you.
And then for the single port, the single port, we also have a chest retractor. And with that chest retractor, it makes, it retracts the chest wall in such a way that you have a very good view and a good diameter to go through. Thank you very much.
Fine, thank you very much. I think your first question was on hypothermia. I think the main problem we have had with our patients and why they become hypothermic is that sometimes the time between coming off bypass and then the time when the chest is closed is long. It's a training center, so sometimes our trainees have to actually close the sternum sometimes. And it is when we just audited our complications that we saw that it was relatively quite high. So I think we have to do something about that. Maybe get a warming mattress or a bear hugger for that. So I accept the fact that it is not good for cardiac surgery. Then in terms of bleeding, what we use is just an ACT machine from Medtronic. It's been excellent, but occasionally you reverse, you get a good ACT, but your patient still bleeds. So you're not sure whether it is a problem with the other clotting agents or whether it is due to platelets or otherwise. So discussing with Dr. Falase, he also thinks that we should get thromboelastography. And I think an investment in it wouldn't be a bad idea. And then somebody asked about the risk factors of that would go into the postoperative period. Yes, a lot of our patients are sometimes very bad. Very low ejection fractions, low cardiac output, sometimes marginal increase in pulmonary artery pressures. I do the right-sided pressures measurements for our surgeons sometimes. So sometimes we decide whether the pressures are not too high, just marginal, can we have a go? and then we discuss with the relatives, and then we have a go. So occasionally we have people who are just on the line or slightly on the other side. But then we look at the risks and benefits of not doing the surgery, and then we go ahead. And then, of course, our valvular patients with very, very bad ejection fractions normally give us a lot of problems in the post-operative period in terms of low cardiac output state. So those are the main risk factors that we, as anesthetists, would be very worried about. Then for Prof, the Merinon, every patient who we think has right-sided failure or heart failure, significant heart failure, pre-op, anyone whose pulmonary artery pressures are shown to be on the high side pre-operatively by a cardiologist, or anybody who has very significant left to right shunt with a large pulmonary artery, we give all of them the loading dose of the Merinon on bypass. So what happens is that they vasodilate on the bypass, and therefore the perfusionist deals with it. And then we continue the infusion into the post-operative period. When our patients don't respond well to our normal inotropic agents, we always add the Merinon to it, and it's been good for us in our patients with right-sided failure. Thank you.
I'm glad to hear that some other colleagues are doing some bit of work with VATS, definitely. To answer the concerns about cost is an issue that we all think about. What I showed you was a breakdown where we've costed and everything is paid for, including the replacement cost. So you can actually sustain that program. In the last 5 years, we've been able to do VATS, and we're trying to increase the numbers. If you have a program where you don't pay for the staplers, you don't pay for the theater fees, then you have what we've always had. Theater breaks down, there's no linen, there's no gauze. We have the bit of a unique situation. We have our own accounts, and we revolve our own funds in the cardiothoracic division. So everything is costed by us, and the money comes back so we can do the next procedures. Any breakdowns is not the hospital. We fix all our equipment. I've had to send instruments out to Germany, out for months for repairs. So you've got to factor those costs in. Now, certainly, the diagnostic costs are much lower. Our main costs are theater costs, stapler costs. We can't influence that very much. For things like malignant pleural effusions, fantastic, and your cost, of course, will be lower because you're not using any staplers, and your local cost would vary.
Okay, so I'd like to thank all the speakers very much for their excellent presentations, and thank you all for your contributions.
Thank you very much, Dr. Badu and all the speakers. Dr. Abode Falashe will give us a brief presentation on the proposal for the West African database.
We have the various things on the cardiac history, angina status, dyspnea, number of MIs, and all the usual stuff you collect in your cardiac history. The various things that contribute to your risk factors. Are you diabetic? Do you smoke? Hypertension, renal disease, preoperative pulmonary disease, respiratory disease, all the usuals. Various cardiac investigations, left or right heart cath, the findings on the cath, the extent of coronary disease, how many coronary diseases there were, was there any left main stem disease, what